Welcome to this session. David Weber from the University of North Carolina in Chapel Hill in the United States. I'm going to be talking about reprocessing semi-critical items, and I'm going to focus on ultrasound probes. I particularly want to thank you for having such beautiful weather. I would have not expected in February. It'd be I don't know why I brought my umbrella, 20 degrees, it's beautiful. I live in the southern part of the United States where it's about 5 degrees today and sort of rain, snow, so this is wonderful, and I greatly appreciate it. But I love coming to London. I'm actually a fellow of the Royal College of Medicine. It's always great fun to come here, so thank you for inviting me. So this is a sort of famous diagram from Bob Weinstein from many years ago that describes the infectious disease hazards in the hospital, and you're all familiar with this iceberg. Most infections come from a patient's own flora, surgery leading to wound infections, vascular devices to bacteremia, endotracheal tubes to pneumonia, and bladder catheterizations to urinary tract infection. But he did point out that many infections go patients to patients, and the environment plays a role. We're particularly worried about MRSA, VRE, C. difficile, Acinetobacter. These days, carbapenem-resistant Enterobacteriaceae norovirus. And he looked at the different types of infections that we see, and he estimated that about 20% of infections came from the other, which he, in the article, described as the environment, that really include room surfaces and medical devices, and I'm focusing today on medical devices. So over the next half hour or so, I'll provide you, a little more than a half hour, an overview of semi-critical medical devices, talk about definition, high-level disinfectants, associated outbreaks, and cleaning and disinfection. So the scheme that we use, not only in the United States, but used around the world, and it has been revised over many years, and this is from the CDC guideline, of which Dr. Rutel and I were co-authors from 2008. I should say we're in the process of revising that guideline, and we hope to have a revised guideline that will be published. We'll work on it through this year, and we're hoping it'll be published early next year. But E.H. Spalding believed that how an object will be disinfected depended on how the object's intended use. And he broke it down into 3 groups. Critical, these are objects that normally enter sterile tissue of the vascular system and through which blood flows, and this would be like an artificial hip, pacemaker, surgical instruments, and they should be sterile. And that's used in an absolute sense, meaning devoid of all microbes. Semi-critical items are objects that touch mucous membranes or skin that's not intact, and they require a high-level disinfection process that kills all microorganisms, except it may not kill very high numbers of spores. And those will be things like endoscopes, as we'll talk about today, ultrasound probes, and others. And then you have non-critical items that are objects that only touch intact skin, and this in general would be surfaces in the hospital, such as bedside rails and buttons, and those require low-level disinfection. Now, in the United States, there are a number of FDA-approved methods of high-level disinfection of semi-critical items. I've listed for you some of those here. They include various numbers of chemicals such as glutaraldehyde, orthosaldehyde, hydrogen peroxide, and others. And they require times of anywhere from 8 to 45 minutes, and at times different temperatures for activity. When you look at disinfectants, there again, keep in mind here that if we had a spore, high-level disinfection will not necessarily kill high numbers of spores. And the level of sterilization, of sterility assurance for sterilization generally is considered 12-log kill of the most difficult to kill organism, the most inaccessible spot of the device, and so that really is meant to be in an absolute sense. High-level disinfectants, though, will eliminate many spores if they don't kill them all, mycobacteria, non-envelope viruses, particularly the problem for us and around the world is norovirus with many outbreaks, fungi, bacteria, enveloped viruses, and high-level disinfection generally has a sterility assurance of 10 to the 6. So in terms of semi-critical devices, their transmission, is through a direct contact. The device is contaminated by use on a previous patient, and the transmission to the next patient if either cleaning and or high-level disinfection is inadequate is through direct contact. The control measure, obviously, to prevent such transmission is adequate cleaning and high-level disinfection. And although I may not always mention it, it's clear that whenever we perform sterilization and we perform high-level disinfection, cleaning must always precede high-level disinfection. Cleaning removes somewhere in the order of 2 to 4 logs of organisms, so that's just physical removal. But it's also important that high-level disinfectants, being chemicals, must have contact in most cases with the object. And if they're coated with lubricants and, or dried blood or other material, then an adequate cleaning will lead to, even with appropriate disinfection, may lead to inadequate disinfection. So cleaning must always precede that. I do want to talk about endoscopes. They are the most hazardous device we use in hospitals in terms of outbreaks. Greater than 100 outbreaks related to predominantly GI endoscopes, but many other types of endoscopes as well. And particularly a problem for the gastrointestinal endoscopes and duodenoscopes particularly. There really is no level of safety. That is, the microbial load on a GI endoscope or colonoscope is on the order of 10 to the 7 and 10 to the 12. If you add in the 10 to the 6 from high-level disinfection and the 10 to the 4 from cleaning, you would see you really have no margin of safety. And I'll come back and talk about that more. They're complex. They have biofilms inside their narrow, long channels that make them difficult to clean and difficult to high-level disinfect. Other semi-critical items, there have been outbreaks, but it's much less common. But there's still enough outbreaks that we absolutely have to adhere to proper cleaning and proper disinfection. And these include ENT scopes, endocavity probes such as prostate and vaginal and transesophageal, laryngoscopes, cystoscopes, and others. They have a much lower microbial load than does an endoscope. They're much less complex. Many of them don't have lumens, and therefore cleaning and disinfection is easier to achieve. But again, if you do it wrong, you will have outbreaks. And so Dr. Rutella and I have summarized the outbreaks and infections associated with semi-critical medical devices. This paper is currently in press and will appear around May or June in the journal, American Journal of Infection Control. And you can see here, we'll talk more about vaginal probes and some of the concerns there. There have been a number of outbreaks, I should say, in those associated with contaminated ultrasound gel. And there have been some putative outbreaks associated with probes, but none as well documented as some of the other devices. You can see here there have been a few outbreaks with laryngoscopes, some more outbreaks with ureteroscopes and cystoscopes, transrectal ultrasound-guided prostate probes. There's been one outbreak in the literature. A number of outbreaks with transesophageal echocardiography probes. A couple with applanation tonometers. Those are used for measuring pressure in the eye to look for glaucoma. But you can see here that with GI endoscopes, there are approximately 130 outbreaks described in the literature, including, unfortunately, a few outbreaks where hepatitis B or hepatitis C was transmitted. None with HIV, but HIV is much less infectious than hepatitis B and hepatitis C. And I should say for these outbreaks, you should look at these as the minimum risk, not the maximum risk, because many of these, the patient would either get colonized with the bacteria and then weeks or months later become infected, and nobody would link it back to the semi-critical device. Or in the case of things like hepatitis B or HIV, again, with an incubation period of months, linking it back to a device and proving it would be either rarely done or very difficult. So you should look at these as only the tip of the iceberg of the hazards of these devices. Now, as I've mentioned before, hepatitis B and hepatitis C transmission has been shown. Fortunately, it appears to be rare. 4 reports related to breaches involved in GI endoscope reprocessing. None via HIV yet, because the risk of that is probably less. We talked about the greatest evidence for transmission associated with GI endoscopes and bronchoscopes, particularly the endoscopes more than the bronchoscopes, but that's likely due to microbial load, the complexity, long devices, thin lumens, biofilm formation in the side, rips, tears, and others are likely to be associated with that. Now, this was a nice, older review article on transmission of infection by endoscopy. And again, you can see that the number of different outbreaks with GI endoscopy, ERCP, and with the duodenoscopes, particularly a problem, and then the bronchoscopes. And the type of organisms vary. So with the ERCP, it's been particularly Pseudomonas. With upper GI, H. pylori has been a problem, particularly when we're using manometry probes and before we did proper high-level disinfection. Salmonella has been an issue. Bronchoscopes obviously are different organisms, Pseudomonas also, but Mycobacterium, non-tuberculous Mycobacterium, and Mycobacterium tuberculosis have all been an issue. And as you can see, these have led to patients becoming colonized a number of times and patients being infected a number of times. So again, most of these transmissions in the past, up until recently, we felt were due to inadequate cleaning and inadequate disinfection. Now, this cleaning and disinfection is enormously difficult. There could be 100 or more steps in proper cleaning and disinfection. So it's easy to make mistakes. More recently, and again, in a different article in Press in the same special issue, Dr. Rutel and I looked at some of the endoscope-related outbreaks now of multi-drug-resistant organisms. The importance here I want to point out to you, these are without reprocessing breaches. Most of the previous outbreaks were related to either inappropriate or inadequate cleaning or a problem in doing disinfection, not brushing the scope, not connecting the scope in an automatic enzyme reprocessor to the flow, so there was no disinfectant flowing in it. Diluted disinfectants that were below the use concentration. But here we now have a number of outbreaks in which, as reported, everything was done correctly. Cleaning was correct, and all the reprocessing was correct. And you can see that they are really duodenoscopes. They are more complex, particularly the complex elevator channel, which is very difficult to clean and easy for debris to be there. And you'll notice that the organisms here are all multi-drug resistant. Again, you should look at this as the tip of the iceberg. Why these organisms? I think that we are saying regular E. coli Klebsiella, but we can't recognize it. Weeks or months later, the patient develops a urinary tract infection or whatever, appendicitis, but you wouldn't know that the organism there is one that was transmitted from another patient. These unique and uncommon organisms allow us to do a molecular link, so where we can link 5 patients all with the same organism. The only thing in common is the endoscope. And in many of these cases, you've found the resistant organism in the endoscope as well. So patients have the same organism found in the endoscope, molecularly linked. So this absolutely proves it's person-to-person transmission through this semi-critical device. And as you can see by the number of authors, these are multiple authors, multiple countries. So this is an ongoing problem. Again, why do we see this? There is no margin of safety. It's either non-existent or minimal. Again, GI endoscopes, particularly the colonoscopes, very high burden. I should say, by the way, in a surgical instrument, the burden on surgical instruments is 10 to the 2 or less. It's just, you're in a sterile field. You've cleaned the skin. We've heard about airflow in the operating room. So they have very low burdens, whereas these are much, much higher. Again, cleaning reducing 2 to 6 logs, high-level disinfection 4 to 6 logs. Again, you can see that you have really no margin of safety, and then biofilms contribute to probably the failure of endoscopes. And as I've already mentioned, these are heat labile, most endoscopes, lumen endoscopes, so you can't use sterilization, long, narrow lumens, right-angle bends, rough and pitted surfaces, springs and valves. Damage may impede microbial exposure, so inside, if you brush it, it can be damaged, and you get little nicks and tears that allow the microbes not to have contact with the disinfectant. Heavily contaminated, so that is a problem. So current low-temperature sterilization methods are new. What do we have for the future? What can we do? Well, we need to move, in my mind, and Dr. Rutella's mind as well as others, we need to move to away from high-level disinfection for these complex endoscopes, and we need to move to sterilization. So we either need new sterilization processes that will work at lower temperatures, or we need better scopes that allow steam sterilization. And we need to move from 10 to the 6th assurance to 10 to the 12th, which would guarantee patient safety. And that really is our goal. We really should to be able to walk into a room and tell a patient that the device they're using will not contaminate them with somebody else's flora. I think that's really inexcusable. There are 2 now FDA-approved low-temperature sterilization processes. Disposable endoscopes and bronchoscopes are increasingly being used at my hospital. For instance, in our intensive care units, about 95% of our bronchoscopies are done with a sterile disposable scope. It's probably not very good for the environment with all those scopes, but at least cost-wise, when you look at the time and effort it takes to clean a scope, move it downstairs to central sterile services, process it, return it, actually it turns out to be cost neutral. So it's not a cost issue for using these. It may not be very friendly for the environment, filling up our landfills, but that's certainly an option. Unfortunately, while they've made a good disposable bronchoscopes, they've not been able to do that yet with the more complex GI scopes, particularly the duodenoscope there. So another option is to develop a steam sterilizable GI endoscope. We don't have those, but we do have one bronchoscope that can be steam sterilized. We can move away from endoscopy to diagnose a colonic disease, capsule endoscopy that takes pictures, new sterile or blood tests to detect things like GI cancers, stool DNA tests, and potentially, which I'm sure our patients would like, just move away from endoscopy, although there are just certain things you need to do with endoscopy, like a biopsy, that you couldn't do with these non-invasive techniques. And finally, improved GI endoscope design. And for instance, we're beginning to see already coming on the market endoscopes that have disposable components, such as the elevator channel, which is the most difficult to clean. So reprocessing semi-critical medical devices, then failures. Obviously, failure to just using a wipe instead of appropriate high-level disinfection. The guideline, the CDC guideline explicitly says that all semi-critical items should be high-level disinfected, not low-level disinfected. Not monitoring the appropriate concentration of the high-level disinfectant at times, that is allowing it to be diluted below its use concentration. Not flushing or brushing channels if it's if it's a lumen scope. And certainly another issue has been not perfusing the channels. Again, if you need contact with the chemical, with the bacteria, inappropriate times and temperatures of automatic enzyme reprocessors are just some of the common errors that we see. An issue is, what do you do as an infection preventionist, hospital epidemiologist, when there's been a failure of this very complex cleaning and disinfection process? Dr. Rutella and I have described in the literature how to assess risks of disease transmission to patients when there is a failure of recommended disinfection sterilization guidelines. I don't have the ability to go over that, but if you want to look at the article, it gives you an explicit way of calculating the risk to the patient. Obviously, if it's high, then the patient should be notified, and at times it may be appropriate to offer post-exposure prophylaxis for things such as hepatitis B and HIV. If the risk is sufficiently low, meaning in the tens of millions, hundreds of millions, or billions, then there may not be even a duty to notify the patient when those risks are so low, because their risk of just driving to the hospital for the procedure could be 1,000 times greater than the risk of acquiring an infection. Again, we've updated that article in the American Journal of Infect Control. It's 15 steps that you can find at the website for the article. Confirm the failure, embargo, and properly sterilize disinfected items, and investigate the cause. The steps provide a general outcome, but each event is unique, and you must be flexible and adaptable. Communication among all the key stakeholders, meaning the patient's physician, operating staff, central sterile services if they're involved, risk management, legal, public relations are very important. It's certainly ethical and appropriate to notify patients, I've said, if there's a risk. But there may be times where the risk is so low that you do not need to do that. And obviously the goal is to, one, fix, the major goal is besides taking care of the individual patients who are exposed, but identify and fix the problem so it doesn't occur again. Fix the individual problem that happened, and then fix the system so the problem does not happen again. Now, in terms of endoscopes, we need to say reprocessing lapses resulting in patients' infections and exposures, and we need to, there's an immediate need for healthcare facilities to review their procedures for cleaning, disinfection, and sterilization. Healthcare facilities, this was from CDC and FDA, healthcare facilities urged immediately to review current reprocessing practices to ensure compliance with device manufacturers and guidelines. And a key part of this, I should say, is because this is very complex, is training upon hire and at least annually of everyone who's doing high-level disinfection. Many of the people doing this, they're not trained like nurses or physicians or other well-trained people, and they need very careful training. They need to demonstrate and document competency. And then there should be audits to assess all reprocessing steps, including cleaning, disinfection, concentration, contact time, the sterilizer, and feedback from audits to personnel regarding adherence. At our institution, at my hospital, for instance, this is just an example of what we do. Class size is limited to allow a lot of interaction between our infection preventionists and the people we're training. You can see it's a 3-hour, it's a multi-hour class. The initial training is the longest, but each year the training is extensive. And then in addition to the training, then there's on-site observation. So not enough just to train them in a classroom setting, but they must demonstrate competency to an appropriately trained supervisor under direct observation at least once a year. And the things in the class are high-level disinfection, semi-critical devices, understanding their responsibility, learning about the pitfalls of adequate high-level disinfection, learning about our regulations in the United States. This particular class was done by one of our infection preventionists, Judy Bringhurst. So it's very important. This is a key part in addition to having proper equipment and maintenance as well. Let me go on now and talk about semi-critical medical devices, and I'll leave time at the end for any questions. And I want to focus on endocavity ultrasound probes. Again, I'll talk about outbreaks. I'll talk about frequency of contamination following use, infection risk, and cleaning and disinfection. This, of course, is just a picture of a probe. These are more and more widely used for a variety of reasons, in particular, obviously, for searching for cancer, but in women, obviously, probes may be used for other medical problems. Well, some of the outbreaks associated with endocavity medical probes, you can go all the way back to esophageal probes that we used to assess gastric pH. And here I'm going back to the 1950s, 1960s. There were many, many outbreaks. They were called epidemic hypochlorhydria, and essentially a change in the gastric pH. There were sites all over the world reporting these, and the pathogen turned out to be Helicobacter pylori. Now, keep in mind, we didn't know Helicobacter pylori exists. We now know what they are in retrospect, but at the time it was unknown what the pathogen was causing these outbreaks. And the problem was that they were wiping the probes with a low-level disinfectant, or sometimes in the cases just soap and water, and these were quite extensive throughout the world. And I've just listed for you a number of the references there, and these are really not necessarily individual outbreaks in these references, but lists of outbreaks. There have been outbreaks associated with electronic rectal thermometers and continuous rectal probes. Here was an outbreak in a neonatal intensive care unit. Again, a multi-drug resistant Enterobacter. And again, don't focus on the fact that these are multi-drug resistant. There's nothing unique about it, except they're easier to identify compared to normal flora. And the frequency of contamination post-disinfection with 80% alcohol was 10%. Alcohol hand rub was 20 to 40%. So they were actually using hand rubs designed for hand hygiene, and that's what they were using on the probes. And again, when you at least use a wipe, you get physical removal plus the alcohol, but obviously if you just put alcohol on and then rinse it off, that was highly inadequate. Another outbreak for electronic rectal thermometers on the probe handles. Again, a multi-drug resistant organism, vancomycin-resistant enterococcus. And again, these were linked to the first one by PCR, again by pulse field gel electrophoresis, showing the power of these new molecular techniques to identify these outbreaks. And then a transesophageal echocardiography probe. Death of a patient due to hepatitis B may have been associated with the failure to appropriately decontaminate the probe. Risks associated with endocavity probes when high-level disinfection is not recommended. This was a study assessment of risks associated with a whole variety of types of probes, transesophageal echocardiography, transvaginal, transrectal probes reported in the in Scotland. Patients undergoing a transvaginal scan were 41% times more likely to have positive bacterial cultures and 26% more likely to be prescribed antibiotics in the 30 days after ultrasound probe versus matched controls. Again, showing you that this is really the tip of the iceberg. Now, of course, these were ordinary organisms, and so they're not molecularly linked, so maybe all of these were really related. But again, you have a control group just showing you the importance of using high-level disinfection and the risks when you do not. Patients undergoing transrectal scans were 3.4 times and 75% more likely to have a positive culture and be prescribed antibiotics respectively. Human papillomavirus, difficult to inactivate, obviously a widespread sexually transmitted infection, although we talk about it as sexually transmitted, and it is. But actually, speaking as an epidemiologist, this really should be seen more as a direct contact transmitted agent. Certainly it's transmitted during sex, but it can be transmitted and has been just by touching and rubbing and by contaminated devices as well. And you can see here that the goal was to assess contamination of gynecologic equipment, and 18% of the samples were positive for human papillomavirus. Particularly concerning are the cancer risky ones, the high-risk HPV that are associated with cervical cancer. Now, many viruses have been associated with cancer, but the one most associated is HPV, and that's something like 90 to 95% of all vaginal cancer, cervical cancer, which is related to HPV. It also causes vaginal and vulvar cancer as well. The goal of this study was to assess contamination of vaginal ultrasound probes for HPV in a Hong Kong emergency department. The probe was protected by a condom, disinfected with tea spray, disinfecting detergent. HPV was detected by, again, PCR because it's not culturable. 120 surveillance cultures, 9 the HPV was positive. Post-procedure and disinfection, you can see that 3 of 14 were still HPV positive. So again, the problem after low-level disinfection, even with the probe cover, can lead to contamination of the probe, and and this will potentially lead to transmission with, again, results years later when a woman could develop vaginal cancer. The problem with probes are twofold. One, they often fail. And the second problem with probes is just in the process of removing them, if you touch through your hands or the probe itself, the cover, you can contaminate the underlying probe. So while I certainly recommend their use when it's possible because they do decrease the bioburden on the probe itself, they do not allow, at least in the United States, the guideline explicitly states that a probe plus low-level disinfection is inadequate. Even with the probe, high-level disinfection is recommended for disinfecting semi-critical probes, not probes used on intact skin, but semi-critical probes. Again, we were talking about, as we talked about HPV, contamination of vaginal sex toys with HPV after cleaning. And again, these would transmit the disease potentially from person to person. Again, a cleaning agent, a liquid consisted of ammonium, chloride phosphate, benzyl alcohol, detection of HPV, again, by PCR, and post-cleaning, majority of sex toys still positive for HPV. So again, a device touching the vagina, potentially the rectum as well. HPV is very common in the population, and cleaning and low-level disinfection is just not going to eliminate this pathogen, as we've seen. Probe covers will help, but again, they still, unless one does high-level disinfection, will not eliminate contamination there. Again, a risk of HPV contamination post low-level disinfection of endovaginal ultrasound probes there. 217 samples before low-level disinfection, 200 samples afterwards. HPV DNA detected in 61 pre-exam and 18% post-exam, and HPV DNA detected in 6 samples post the low-level disinfection. So again, conclusion on multiple studies, multiple people, is that low-level disinfection, even with the probe cover, will often fail, leading contamination of the underlying probe. And our patients expect that when we use a medical device on them, they understand there are risks of every procedure, and we explain those to the patients. They do not expect to have any chance of acquiring an infection because that device was used on a previous patient. Again, infectious risks of endovaginal and transrectal ultrasonography. Again, assess the frequency of contamination following use of these devices. This was a review, a systematic review and meta-analysis that Dr. Leroy presented in the Journal of Hospital Infection several years ago. Looked at 32 studies. The pooled prevalence was about 13% for pathogenic bacteria and 1% for frequently occurring viruses after low-level disinfection. So again, a whole host of studies showing that. And the pooled prevalence of infected patients after transrectal ultrasound and guided biopsy was estimated to be 3.1%. As you can see, the prevalence of contaminated probes with pathogenic bacteria after removal of probe sheath, again, covered, and after the cleaning procedure. And I was an author of this as well, and we did a computer model assessing the risk of infection via endorectal and vaginal ultrasounds in France using a stochastic Monte Carlo simulation. The result would be our estimate in France, HIV, 40 new infections, and that other viral diseases, particularly things like HPV, somewhere between 2,000 and 15,000 infections would occur by the use of probe covers and low-level disinfection throughout the country. Again, the problem is the outbreaks that I've shown you we're using molecular techniques only if someone has a unique bacteria or virus, just the tip of the iceberg that's likely occurring. And the conclusion is that you really need to adhere to the CDC guidelines and other guidelines that recommend appropriate cleaning followed by high-level disinfection. And it's certainly appropriate to be using a probe cover, and you certainly need to use a sterile gel as well. Risks of contamination of ultrasound probes and reports of health care-associated infections due to endovaginal exams, and a paper just published in the Israeli Medical Association Journal. This was done by the Israel Minister of Health. The 2017 guidelines for disinfecting endocavity probes remove the probe cover, change gloves after adequate, hand hygiene, pulmonary hand disinfection, clean the probe using special pads or wipes, clean with a high-level disinfectant, including a chemical or physical method. And this is a direct quote out of the guideline. They included ultraviolet light as one of those possible methods. You can see here they did note in studies, they did quote our study, the meta-analysis with this estimates. But again, this is just one of many studies in the literature there. You can see they have 2 prospective studies and a blinded study there demonstrating substantial bacterial contamination here, 3.4%, and for viral contamination here, you can see anywhere from 1.5 all the way up to 14% when evaluating the risks of contamination. And then when one looks at case reports of healthcare-associated infections from endovaginal probes, you can see that they list 2 studies there. And one case, the source was ultrasound gel that they've listed. The other was the medical staff. So again, evidence of actual infection. The cavity probes, these include transesophageal probes for echocardiography, vaginal rectal probes used in ultrasound screening, as well as we have these probes for mucous membranes, and the guideline recommends that high-level disinfection. Sterile probe covers have a very high rate of perforation before use, 65% in one sample, and very high rates of perforation after use. There are studies after oocyte retrieval use, for instance, 75 to 81%. Others have found lower failures, but it's still, again, 1 to 2% is still a significant rate of failures, and condoms are superior to probe covers. I want to briefly note that intrinsically contaminated ultrasound gel, there are many outbreaks here of that, so you do need to be using sterile gel, and these have occurred with a variety of probes and include things like mycobacteria, Burkholderia cepacia, Pseudomonas, and others. So what are the newer technologies we can use? One is a supercharged hydrogen peroxide mist. Another is ultraviolet light. Both of those are virucidal and bactericidal there. The CDC guideline, as I've said, provided a minimum high-level disinfection for these probes. Again, even if probe covers have been used, clean and high-level disinfect semi-critical probes as part of the guideline there. I'm going to skip this and just go on. Methods used for decontamination of ultrasound probes, recommended sterilization, disinfection. In a survey, even in the U.S., where we recommend, by the way, high-level disinfection or sterilization, you can see most people do it, but we still had, in a survey, 3% of people not doing it, unfortunately. Let me turn briefly in the last few minutes to ultraviolet light. Ultraviolet light at particularly 254 nanometers is highly virucidal and bactericidal through a whole variety of issues. It dehydrates the DNA. It splits the DNA strands apart. Fuses the DNA. So it destroys the organism by destroying the genetic material. And ultraviolet light has been used many times for many things in healthcare societies. You can go downstairs, you can see all the machines they have here for you to look at for surface disinfection. It's used for water disinfection for Legionella. It's been used for disinfection of air, and more recently for surfaces. If you look at UV, it's rapidly microbiocidal at the wavelength 254 is the best. It is time dependent and energy dependent. The higher the amount of energy used, the faster the time. And it's distance dependent, and it falls off as a square of the distance. So the closer you get, the faster it works. Advantages of ultraviolet high-level disinfection. And here we're talking about specifically the Chronos system. Ultra fast, 90 seconds to 180 seconds, so very fast. Just push a button, it's easy, it's non-corrosive, there's no chemicals. It's simple, it's fully automated, measures the dose so you know that it's worked, and gives you a readout, electronic read, as well as a paper read of that it's been worked. It's compatible with more than 700 models of probes. And because it's so fast and so easy, minimal training, it's cost effective. I should say, as with every other type of high-level disinfection, cleaning still should always be done before high-level disinfection. If you look at the effectiveness of UVC to inactivate human papillomavirus, which we've mentioned as being a major problem and concern, both because of its frequency and its relatively insensitivity to chemical disinfectants, you can see here that it's enormously effective, multi-logs effective in just a very brief period of time against human papillomavirus. Nice study by Dr. Kack assessed the effectiveness of UVC for disinfection of probes. Again, they were wiped, antiseptic sprayed, and microbial dry wiping, antiseptic wiping was 98% effective, but again, you're still missing 2%, very important, and ultraviolet light was 100% effective. Another study here, a goal was to assess effectiveness of disinfection plus UVC, cleaning with the towel impregnated with the disinfectant spray versus ultraviolet light. After the probe cover was removed, pathogenic bacteria were found for 3.4% of 440 probes and viral particles detected on 1.5%, but after cleaning and UVC disinfection, no pathogens or viral genome were detected. Again, the standard methods are quite good, but ultraviolet light is faster, easier, and better. Currently, this UVC devices are approved in France and Canada, pending in the US and the UK as well. Their basic research there has been completed, and product has a potential value. And the same thing is true in Scotland in terms of its use. I'm going to skip in the time prostate probes, and I'll just stop and say thank you very much, and I'm happy to answer questions.